You walk into the emergency unit in Nigeria. You feel unwell, very scared, or even in pain. You're seen by a doctor. He hands over the prescription to you, and you're told to get the consumables on that prescription. The emergency has been paused. You're sent to the pharmacy, maybe on the hospital premises or outside the hospital. Let's start with the hospital premises. You get there, you get on the queue, and you're unable to get these consumables because they do not have. You have to cross the road to get these consumables. Your care becomes fragmented, and in that moment, survival quietly becomes a test of logistics, money, and speed rather than medicine. This is not about blaming the clinicians. It's about a system that has normalized interruption of care at its most critical state. Hi Prevention Circle, my name is Halima. If you remember vividly, I informed you I was on a mission to create my Nigerian Healthcare Dream. And this is not just creating a Nigerian Healthcare Dream. I am bringing my experience. I haven't worked in the NHS for a while now. I believe it's ideal to give back this experience. I truly believe in my Nigerian Healthcare Dream. In the UK, especially within the NHS, emergency care works on a different principle. When you arrive, typically in the NHS, there's something called the triage system. It happens immediately. Don't get me wrong, I know that we have a triage system in Nigeria. Cases are prioritized based on the urgency or life-threatening conditions, and they are categorized into green, amber, or red. Red stands for an emergency that is life-threatening, and they mostly transfer patients like this to the resuscitation department. All patients would generally be seen in the emergency unit. However, sometimes when the condition is clearly visible to everyone, there might be a direct referral to the specialty in focus. Prescriptions are not handed to patients in emergency. Medications are administered on the spot. Care flows around them. The system is the one that actually absorbs the chaos, and the patient does not have to absorb the chaos. This is very understandable. A patient coming to the hospital is already traumatized. People do not have to go through this kind of horror in the name of providing healthcare. The NHS is not devoid of its errors. It is definitely not a perfect system, but the national insurance contribution is a quiet but powerful tool that enables the NHS work in emergency. Imagine these funds are made possible such that the treatment is being paid for even before the patient arrives. The medications are started, the investigations, and even the staff are covered using this fund, such that the priority is placed on saving the life and the cost can be implemented later. Nigerian can actually adopt the system. Nigerian can start a mandatory health insurance pool that covers emergency care. Someone will say, oh, when we save this money, the politicians, to the politicians, when these monies are provided or when they are donated by individuals, this is not the time to start siphoning or embezzling. This life, we've come with nothing, and we're definitely going to live without anything. Let's try to put each other at the heart of what we do. Nigeria doesn't need to copy this fully, but it can adapt the idea. A basic mandatory health insurance pool that covers emergency care would remove the need to hand over prescription. Someone somewhere will say, oh, they're going to embezzle. I know the system. I understand corruption can be a problem. But please, let's hold each other accountable for whatever donations we make. These donations are to save lives. This is not the time to take this money and use it to send your kids. Now I'm speaking to politicians, and use it to send your kids abroad. And here is a fact. The NHS we're talking about, Nigerians are deeply embedded in this system. Nigerian doctors, Nigerian nurses, Nigerian pharmacists, healthcare assistants, porters, IT staff. They don't just work in the NHS. They help to keep it standing and other nationals. They understand the triage system. They understand escalation. They understand protocol and continuity of care because they practice it daily. The knowledge gap is not the problem in this instance. The structure is the problem. What is my action plan? I don't want to sit down here today and just lament. I have come bearing action plans. Here are what changes looks like without waiting for miracles. One, we need an emergency medication cupboard. I know there are in Nigeria, but are they well equipped with medications that are actually needed? Someone will say, oh, someone is going to steal it or someone is going to take it home. Over here, they don't just leave all these medications lying around. There are rooms where some of these medications are kept in. No one has access to those rooms. Even as a doctor, there are places that you do not have access to. Even as nurses, there are some medications that would require you signing with someone else that you've picked that medication. There are cameras everywhere. So there's no point saying, oh, we can't trust. There are things that can be done to ensure that stealing is out of it. Two, simple triage training. You don't need anything fancy. You don't need all the gadgets in the world. Basic triage protocols can be taught to nurses, to doctors. It's short, repeatable sessions, color coding. I know these things are available, but let's keep emphasizing and re-emphasizing. No overcomplication, just make it simple. Three, remove the prescription handover in emergencies. For every patient that walks into that government hospital, let's eradicate handing over prescription to patients. These patients are traumatized coming to the hospital. Handing over those prescriptions further traumatizes them, and some of them don't even return. Number four, diaspora-led mentorship. It doesn't have to be me. There are doctors in the United Kingdom that have been practicing for over 20 years and they are well equipped to give adequate information on how to go about these things. You don't have to meet me. You don't even have to transfer, or you don't have to send delegates to come over. Some of these things could be done virtually. Some of these things could be done remotely. We could do training remotely. You don't have to come here to see how the system works. You have personnel on ground that are able to provide this information, that are able to provide this experience, and together let's make the Nigerian healthcare system work. I know this is already happening in the private sector, but let's bring it to the government sector. I know it's happening informally, but we need coordination with this. Five, let's have a pilot study. Pick a hospital. It could be Lagos University Teaching Hospital. Let's test the changes within 6 months. Collect data. This helps to show improvements. No grand speeches, just proof. This is not about copying the NHS whole scale. It's about adapting what already works, using people who already know the system to make it happen. Nigeria doesn't lack intelligence or skill in healthcare. It lacks system that protects patients when they are at their most vulnerable moments. And this is fixable.